I'm a specialist in emergency medicine and internal medicine at Queen Elizabeth Central Hospital, and also a clinical lecturer at College of Medicine. Thank you.
Thank you so much for the introductions. The main question for this panel discussion is what lessons can we draw from COVID-19 to transform the health system in Malawi? This panel discussion is part of College of Medicine dissemination conference, and it's also within the health systems and policy session, which we have already started this afternoon, and another session is going to come tomorrow. But before we start our discussion, we'd like to acknowledge some of the institutions that have made this conference possible by sponsoring this conference. The first one is Ministry of Health, and also UNICEF, World Health Organization, First Capital Bank, John Hopkins Project, Malawi Liverpool Wellcome Trust, Clinical Research, and also MHAP. We thank you for your support, because without your support, this conference would not have been possible. Let me also point out that we will have a session at the end where you'll be given the opportunity to ask questions. For those of you who've joined virtually, you can post the questions on the chat. And those who are watching us, you can also ask questions by texting through WhatsApp on 0999 626 889. I will repeat the number, 0999 626 889. Enjoy the discussion. We will now start our discussion. Due to COVID-19 pandemic, many health systems worldwide have fallen apart. Do you think the health system in Malawi has fallen apart? Let's start with you, Dr. Bridget.
Thanks. I just wanted to also provide context into when we talk about the health system, what it means. I think that helps people understand what we're talking about. So when we talk about the health system, there are a number of building blocks. We're talking about infrastructure, we're talking about health workers, so the health workforce, we're talking about financing, we're talking about technology, and other aspects. So when we actually discussing this, I know a lot of other times we'll discuss other aspects. You have to think about have those fallen apart in essence. My sense is that not really, because although our health system was overstretched, I will obviously talk from a health worker perspective in terms of the health workforce. Our current health workforce is kind of at half capacity. So we're working with about 48% vacancy rate, meaning that already before COVID, we had very few health workers. We had half of what we need to manage the diseases we already have. What happened with COVID when it was coming was that we were obviously very scared, frightened about the reality of this new pandemic coming on board. Already we have HIV, malaria, and all the other diseases that we're trying to deal with, and we had half of the staff that we needed. And I think we were, if the numbers that had been predicted had actually been at the volumes that were there, our system would have fallen apart. But as it stands, we got by somehow and navigated through it. I think it showed us as we were starting to do the preparations that there were gaps that we already knew. As I've said, we already knew that we had an overstretched health workforce that was strained already because they were half of what was required. But because the volumes that came into the hospitals, and I'm sure Dr. Wood will speak to his experience, it wasn't so overwhelming that things went completely haywire. I think we saw the gaps, we saw even additional areas we could have done better, but didn't really get to the point where everything went wrong.
Thank you, Dr. Rewesi. I will now move to Dr. Fosipo. Do you think the health system in Malawi has fallen apart due to COVID pandemic? Dr. Fosipo?
I had muted myself, but we are answering this. I want to assume that I'm answering the same question on if the health system has been collapsed by the COVID-19.
Yes.
But my thinking is that our health system has always been relatively weak. That's why the Minister of Health came up with the Health Sector Strategic Plan 2, which is aiming at strengthening the health system. So this COVID-19, when it came, it showed that it is resource demanding. And that resource demanding, already we are looking for resources to build up to strengthen the health system. And this showed us that it needed more resources. So it just shook the health system more than it was. So it's not necessarily that it has collapsed, but maybe fortunately for us, we have been implementing the primary health care, and our primary health system has been relatively stronger. And so we have depended on that one most to make sure that at least we are relatively resilient, and we definitely we have been relatively resilient, not necessarily collapsed, but COVID-19 has given us an opportunity to strengthen the health system as it has been a wake-up call. That's what I can say for now, because as Dr. Nsolomba said, the health system is characterized with the inadequate resources, right from human resource, infrastructure, equipment, even our medicines, the supply chain management needs to be strengthened. And that from taking care of patients and other services, they already shown that we can already see that we still need to do more for us to strengthen our system. Thank you very much.
Thank you. Let's hear from the civil society organization perspective. Mr. Joe, in your view, do you think the health system has fallen apart due to COVID? George, could you unmute?
Okay, sorry. Thank you very much. The question is conclusive, but what we can say is the health system has been affected, and has been affected greatly, both positively and negatively, and to a little extent positively. For instance, the same supplies and resources that were not adequate have now been shared. Some of them have gone to COVID, which is resource demanding. We can give examples of human resources, ambulances, wards, and alike, which means that the very inadequate resources have now been used elsewhere. When we talk about ambulances, they are used to transport those who have been affected. And also, on the other hand, we have seen that a lot of attention has gone to COVID-19, and there should be an expense somewhere to other health conditions. And I said, to some extent, the health sector has also benefited, because we have seen within this period recruitment of some healthcare workers, ventilators being either donated or being procured, and some trainings happening to healthcare workers. The trainings which also are drawing away the healthcare workers, but these have happened. So yes, negatively, the health sector has been greatly affected by COVID-19.
You're making some important and interesting observations there, that the health system has actually benefited from this pandemic. Let's hear from Dr. Ngoma, the director for Central Hospital. How has COVID-19 affected Central Hospitals?
Thank you very much. COVID-19 has affected all our functions. As a Central Hospital, we've got 5 functions. The first function is service delivery. Service delivery has been affected because when the pandemic came, we had to decongest the hospital, which meant we had to discharge patients who were not supposed to be discharged. We were not able to work the way we used to work. We made ourselves working shifts because we were afraid, one, that if all of us become affected with COVID, no one would work in the hospital. We divided ourselves so that we should not use resources at once. So the resources that we had in terms of personal protective equipment, and all the other equipment would be used sparingly. And at the same time, our services being affected. Those patients who needed operation not to be operated on. The clinics were closed, but also there were patients who would come and pay bypass fee. Those patients were refused to do that. But also, as you can see, as a system, we rely also on expatriates, workers, doctors. Most of them were called back to their homes, which meant a thin staffing was available. But also, our staff were demoralized. They were discriminated against in the buses. When they see them, just all in COVID, they were even sent out of houses where they rent their houses that were going to bring COVID. Secondly, our function is to act as a platform for teaching. All health workers have been taught there. As you know, all schools were closed, including colleges. And these students, medical students, nursing students, whatever, they also act as a hand, they give a hand in patient care, which meant patient care was affected, but also we also act as a supervisor for the district supervision.
Thank you very much, Dr. Ngoma. I'll get back to you again. Dr. Molira, could you please explain to us how COVID-19 has affected emergency care, but also other services at Queen Elizabeth Central Hospital?
Thank you for this opportunity to indeed discuss the issues related to it with COVID-19 disease. It's a particular cross-cutting component within our health system that requires particular attention for improving health services, because if I may elaborate on what emergency care is, it addresses unplanned or unforeseen illnesses or injuries that facilitate our public to engage with our health facility. They don't wait for an appointment, it just happens. And these illnesses and injuries have a high risk of resulting in death if they are not attended to immediately. So our health system had been mainly focusing, as we've said, on public health interventions, but also looking at disease-specific illnesses such that we streamlined our cost cut in how we provided emergency care. So the infusion or the positive things that Mr. Yobe has highlighted were actually positive investments into emergency care. Ambulances facilitate a component of transportation of sick and injured patients to the hospital quickly. So that was an amazing investment, but also the skills that were provided to respond to COVID-19 are core basics of keeping a patient alive. We were, as a health system, together, regardless of what particular training, which was exciting to bring back teamwork between health, among health workers, nurses, clinicians. We learned how to the health system without bias and look at, are they breathing properly? Are they having enough blood to keep them functioning? Before or after, or also, are they able to engage with us? So that we were able to make sure that our patient is stable, as we would put it, to receive care. And the care was optimizing and prioritizing how a scarce resource like a clinician can go to see the patient and then identify what type of disease, and indeed streamlining how we deliver emergency care in our health system. It allowed us also to reflect on safety issues and prevention. Another important aspect was the aspect of highlighting why emergency care needs to be addressed as a national issue. It should be addressed within the public sector and the private sector, so that all Malawians who are likely to have an unplanned or an unexpected illness or injury are able to receive the appropriate care. So we found that COVID-19 facilitated the reintegration of emergency care. The other pertinent thing was also to shared resources that was also highlighted. It was very important for that to happen because sometimes the resources within hospitals were streamlined to HIV care or pediatric care. So suddenly we were forced to work together and say, let's look at the patient as they arrive and indeed treat them appropriately. Thank you.
Thank you, Dr. Lee, for the great insight. We'll now move to Professor Mapasa. Professor, could you please explain how COVID-19 has impacted on public health in Malawi?
Thank you very much. I'll be very brief in that COVID-19 has woken us up from deep slumber. We had a public health law which had not been revised for a long time. And then we had COVID. Instead of fighting COVID, we were busy going to the courts to try to see whether we can implement lockdown. It has woken up from a slumber, and I would like Mr. Jobe to help us here that there are certain things that we neglect, but we should be focusing on. So it has helped us to move quickly to start looking at whether we have got the right public health laws to deal with emergencies. It has also given us a lesson on the importance of engaging the community. You saw that health workers were unable to do their work in the first phase of the epidemic because they were being beaten up by members of the community, to the point that the country was struggling to contain the disease. So it has also highlighted the need for the health sector to be in close contact with the community so that it can resolve issues like rumors or mistrust. And this is where people like Mr. Jobe comes in as being very important, so that we shouldn't wait for an epidemic to occur before we have good engagement with the public. Thank you very much.
Thank you, Professor. You have repeatedly mentioned the name of Jobe to comment. Could you comment, Mr. Jobe?
Okay, thank you very much. I would want to agree with the professor that there have been a number of developments. And we can say that COVID-19 took Malawi unawares. It came as a big surprise. We were busy. For example, as civil society organizations, we have been advocating for recruitment of healthcare workers, all of them who have been trained. This was the time now when Malawi listened and tried to be busy. We have been advocating for more resources to the health sector, and we have talked about the importance of the health sector. We have seen that all other sectors went on their knees just because the health sector was affected. As I said earlier on, we have also noted that a lot of attention now has been going to COVID-19. Some procedures are not happening in health facilities, some surgeries and the like. Then again, as the civil society organizations, we have been saying, let us improve our public health sector so that we have confidence in them. COVID-19 brought a situation whereby everyone had to go to a public health sector, regardless of whether they had the resources or not, which is one of the opportunities which can even lead to a policy in Malawi to say, unless there is something which cannot be treated here, every condition must go to the public health sector. The professor talked about the lockdown. Here we can, as civil society organizations, we can talk about somewhere failure to consult. We have seen some decisions just being made and being challenged, which means COVID as a disease requires, and other diseases require collective efforts. And this should be an opportunity that before announcing any lockdown or regulations are put forward, there should be some consultations and listening from the people. Otherwise, COVID-19, to us, we have noted is not only a health issue, it is an economic issue, it has been a political issue, it has different facets. Thank you.
I'll get back to you. Thank you. Dr. Malewesi, could you highlight some of the challenges of how the health workforce has been affected during COVID?
Thank you. I think that Dr. Momo certainly started speaking about some of the direct effects. So there has been some direct effects on the health workforce and some others that have been indirect. I think the most important one that people need to realize is that health workers were in the front line, that they were managing cases, that they were also getting infected. We certainly have seen, I think as of the last count, just under 600 health workers have been infected with COVID in Malawi. And we've had some deaths. I think the last count I've seen 5. So we've lost some of our health workers due to COVID-19, and I think that's the most important thing to mention because that affected, even when, for example, we lost people due to death, but we also, for those 600 that were infected, they had to quarantine, they had to be treated. Some of them were actually severely ill and were admitted.
You pointed out on something that is very important there. There was a time when there was important to take away, but some lost their lives. How did that situation feel?
So I was going to add that as people were getting infected, or even before, I think that because COVID-19 was new, there was a lot of anxiety with health workers, and you saw the anxiety play out in terms of strikes. People wanted PPE, people wanted risk allowances, people wanted to be paid because it's a disease that nobody understood, and we were learning new things every day. So when you're learning new things every day, you never know. People are saying you don't need to wear a mask, or maybe you don't need to wear gloves. We certainly saw sometimes we were trying to say, I think Dr. Momo started saying that we were trying to ration our PPE because not everybody should come and wear PPE. We see people wanting to wear coveralls, and like you don't need to wear a full coverall if you were just sitting in the outpatient, but everybody was so scared. There was a lot of fear and anxiety already, even before managing the patient. And then as Dr. Momo already raised, that the community certainly was stigmatizing, as he mentioned, evicting people. That also affected how health workers could provide services. You can imagine if you're just, even before the ones that are affected, you're just trying to get public transport to go home after a hard day of work, when you already said that they short staff. Maybe your friend has been affected with COVID, you don't know, you're the only one now left in the hospital, and suddenly people are stigmatizing you. It's been sad to see that reaction from the Malawian population.
Talking about the issue of stigma, Prof. Mabata, what do you think was the main cause of the stigma towards COVID-19?
I think it highlighted the challenges we have as health workers, the challenges we have in communicating with the community. We have to create a state of trust. I think it showed that in some ways the community maybe do not clearly understand or accept the facts that we provide. Because of the doubts that the community had about the facts, they were doubting about what sort of disease is this? Are the health workers telling us the right thing? And because they did not trust us, then they started believing in other things that are not technical in nature. And this is why people started stigmatizing other people who were suffering from the disease. So the big thing is that the stigma came around because of the lack of understanding or misunderstanding between the health workers and the community. So this is one lesson that we have to learn as health workers, to communicate very clearly, to build this trust with the community so that cases of stigma may not happen, because at that time, we want to have the community members trust the information that we have in terms of disease transmission and other things and how to prevent the disease. Thank you very much.
Thank you, Professor. Before we continue to talk about some of the key lessons that we've learned, let me just remind our viewers that you have the opportunity to ask the question, and you can text your question through WhatsApp to 0999 626 889. 0999 626 889. Dr. Fosiko, could you highlight some of the key lessons that we have learned on COVID-19 that we can use to transform the health system in Malawi?
Thank you very much. One of the key areas I want to just echo what Prof said, but one of the key areas that we have seen in terms of if we want to strengthen our health system, health is just not disease. Health is everything that we do. So all the sectors need to come together to look into health. So as we, from the COVID-19 response, as we are responding to the COVID-19, we saw different sectors coming together and trying to solve this problem. Resources, some of the resources have come from the private sector, not necessarily those that are dealing with health. The banks came in. We saw some NGOs coming in to support the health system so that we are able to respond to the COVID-19. It brought an opportunity for some resources to be pumped into the system. So that's one of the lessons that, yes, together we can do more. And with the little resources that we have, we can also do more, not necessarily that we don't have enough resources. And again, another lesson that I would want to take from this COVID-19 is to pay attention to our healthcare workers. I think we need to commend our healthcare workers for the very good job well done. But with the little attention that we have been paying to the healthcare workers, maybe we need to do more and ensure that they have got the proper training, they are more resilient, and they start paying attention to other areas which our healthcare workers, we need them to look at. Like, for example, one thing I have learned is that maybe because of heavy workload, our healthcare workers have not been paying attention to data that they collect every day. And that data is the one that informs the policies. So that's one of another lesson that I would want to pick from the COVID-19 response. But teamwork has shown that it works. And we cannot say that we don't have resources. We can always do more with what we have. And definitely we need to pay more attention to our healthcare workers, because human resource is the only resource that manages other resources. That's what I can say for now. Maybe my colleagues can contribute on the others.
Yes, let me just pick from one of the key points that you have pointed out, that there is a need to build a strong and resilient health workforce. Dr. Malewezi, what suggestions do you have in terms of building a strong and resilient health workforce? In which areas should the government and donors invest more in order to build a strong health workforce?
So even before COVID, I think there was an HRH strategy, a strategy plan in line with the health sector strategic plan. There was a plan in place to build on the investments for health workers. So we know that, as I mentioned earlier, we already only have half of the health workers we need. What we need is to build that health workforce to reach what is required. And so there's real need, and I think that it's already highlighted in that health HRH strategic plan about building that workforce, building the numbers, because sometimes you need the numbers. As Dr. Momo was saying, if half the people are gone, it's really hard to deliver the service. Even if I'm the best doctor in the world, if I have too many patients, I can't provide good quality care to those to so many patients. So you need the numbers. So that's something that should continue based on the strategic plan. I think the other aspect that we learned from COVID, which I think Dr. Mulinda was starting to talk about, was getting the quality and the skill mix right. I'll just give an example. I think people at the beginning of the pandemic, people were worried about how many ventilators can we bring into this country, because we only had, I can't remember the number, we only had 10 or 12, whatever it was. But the issue was that even if you brought thousands of ventilators into Malawi, we didn't have the health workers trained to manage those ventilators. So actually, we brought in equipment where they wouldn't have been able to manage. So there's skills. So I think there's also a need for people to start looking at, apart from building up tons of numbers, what are the skills required for our health workers to manage, not just COVID, because I think COVID has been one situation, but every situation, all the health work, all the diseases that are there, what are the basics? And some of the basics, I think, I recall hearing from my Dr. Melinda, how to provide oxygen properly, or how to care for, how to provide vital signs. I think Dr. was also saying how to record the data. If you're not recording the temperature of the patient, how do we know that they're getting better? Those are those small things for quality of the health workers are important to really turn around the health workforce.
Thank you very much, Dr. Ngoma. We pick up from where Dr. Mario has stopped to highlight some of the key lessons that we learned from COVID.
Okay, thank you very much. The major lesson that I've learned from COVID is that we should be self-reliant. As far as health is concerned, we should not rely on other people that were going to refer patients to India. As you know, during COVID, all the airlines were closed, and when patients were supposed to be referred, they were not referred. This is the time for us to build our own systems. We should invest in infrastructure. We should invest in diagnostics. We should invest in human capital. We should invest in pharmaceuticals. That's I think the biggest lesson. But also the other lesson that we need to look at is that for somebody to do something, there is need for three things. First is the knowledge, which my colleague has talked about. Then the equipment to work with. Then the motivation. One can have, if one of these three is not available, forget about work. We know about a concept called passive resistance. Somebody will just go to work, just not doing anything, not even helping patients. Right? As somebody has said, why are people employed in the public service? Somebody asked their employee to fill a vacant post and nothing else. Thank you.
Thank you very much, Dr. Ngoma. Dr. Mulima Nyirenda, could you also share some of the key lessons that we've learned from COVID-19 that can help transform the health system in Malawi?
Thank you. I'm very appreciative of how it has been highlighted on the need for a health worker to be pluripotent in their knowledge, attitude, and practice within a health system. I'll highlight this because emergency care is the stepping stone or a horizontal component that cross-cuts into provision of specialized care. So Dr. Jobe was talking about how I can access an operation. If I focus on just looking at operations, I will forget about something else, same as COVID-19. So emergency care provides the platform where people can remain well looked after, stabilized, especially when they are unstable, and then they receive the actual definitive care. So the biggest lesson that the health system learned was that we need to understand our codependence as specialties. Specialized care exists not as individual pillars, but rather needs to be integrated in a service for it to shine and provide the appropriate care to the patients that we will need the care. The other aspect which was highlighted was also the importance of understanding what people do before they come to a hospital, because the value of our keeping the patient alive and then giving them provision of care is heavily dependent on what my patient will do before they come to the hospital. So indeed, having talked about engagement with the community, understanding access to care factors, because it was evident that access to care was to health services was sort of blocked to certain aspects of healthcare. It is important for us to understand what is the value of an emergency care. I'll highlight this because when we talk about access to care, we need to understand why our people engage with the hospital. And most times in Africa, including Malawi, people come to the hospital not because they want to come and see someone for an operation, that would be planned, but they come to the hospital keeping their swelling, and then they come to the hospital when maybe it has become bigger and they can't tolerate it. That's called an emergency. So we need to have an improvement in the engagement with our community in terms of health literacy aspects, not just about what is disease, what is HIV, what is malaria, but also what are danger signs that require me, regardless of whether I want to go to the garden to farm or to go and sell my vegetables, because this has happened on my body, I must come to the hospital quickly and get the appropriate care. That will improve a lot of things, because COVID-19 highlighted why the mistrust was there. It was because we're not meeting the need of a patient in how we engage with them, but rather the health service was planning itself in parallel, looking at disease burden rather than why patients engage with us. Thank you.
Thank you, Dr. Mulinda. You've tried to respond to the question on the issue about trust. There's a message that we have received from one of our viewers, Grace Soko, and this question is directed to Professor Mapata, and it's in line with the issue about trust. So Grace is asking, Prof, you have talked about community not trusting the health workers' communication. What was so special with COVID-19 that community could not believe, whilst other diseases they do understand? There should be something not only to do with communication. What do you comment, Prof?
Thank you very much. COVID, the way it came, it was a very scary disease and remains a scary disease. There were a lot of pieces of news coming from different angles, from the television, from radio, from friends, from relatives. When you are getting information from so many sources, you need to have one credible source. And in health matters, the credible source has to come from the Ministry of Health. This is where we were exposed that when we have competition in terms of news, our community chose mostly to listen to other alternative sources of information. That's why we had a crisis. That's why they could not actually understand us, because this was a scary disease. We had conflicting information from different sources. And that's where you test whether you are effective as a health system or as health workers in communicating with the population. So we were tested actually against other competitors, and we were found to be wanting. Thank you very much.
Thank you very much. Mr. Yobe, could you also share some of the lessons learned from COVID-19 that can actually help to transform the health system in Malawi? Over to you.
Thank you very much, moderator. The first lesson is that information is power. Some of the confusion that came was because the general public lacked some information. We can give some examples. At first, as Dr. Mapas has said, or Professor Mapas has said, people relied much on social media to get information. Then there came a confusion, which is still there at the moment in Malawi, to differentiate between coronavirus and COVID-19. When someone tested positive for coronavirus, until now, probably now because we are testing people with the symptoms, we have always said the person has been found with COVID-19. And we had some of those who tested positive refuting the results because they did not feel sick. And that caused some confusion. Then the other confusion is when someone dies, who has died of COVID-19, who has died of other health conditions, but was the coronavirus positive. I think that also confused many people.
Thank you very much, Mr. Yobe. Dr. Fonsiko, what do you suggest that the country should do to make the health system to be more responsive and more resilient?
Hello?
Thank you, Mr. Yobe. I'll get back to you. Your connection is not stable. I'll get back to you again. But then I'm moving to another question directed at Dr. Fonsiko. What do you suggest that the country should do to make the health system to be more responsive and resilient to the current and emerging health issues such as COVID-19 and other future pandemics? And when I talk about resilience, what I mean is that health systems that are resilient, they have the ability to effectively prepare for, to manage, and also to learn from over to you.
Thank you so much. I would do, it's quite a big question, but I would say, let's go back to the basics. Prof as he indicated very well, that our legislation has to be in place so that we can respond accordingly to issues. Otherwise, the way we have been responding to COVID, it has been more of reactive. So we have to be looking ahead and go back. We have to go back on the drawing board and possibly look at which areas do we need to pay attention most. And again, at the same time, while we have put up our plan, the execution, we should forget that we'll have all the resources that we need in life. But we should look for ways and means of making our systems more efficient and effective. And that is right from the human resource. The human resource is key. We can't overemphasize on that one. But at the same time, let's look at our systems and look at how do we want to deliver the health services. Because sometimes taking it into through the conventional way we have done before may not work, because we have seen that COVID-19 people needed to be treated in isolation. There may be some other conditions which will come also with other conditions on how to treat them, to manage them. So looking at all those building blocks and strengthen our health system is something that will make the health system resilient, but paying more attention on the community participation. It is very, very key. And we have to encourage innovation, as we have seen with this COVID-19, from the communities, from different academic institutions, even the industry itself. There was some innovation that started coming out. We have to encourage all those things, and those things will also help us to be more resilient. Allow me to stop there, moderator. Thank you.
Thank you very much, Dr. Fonsiko. Now move to Professor Victor Magasa. What do you suggest should be done to strengthen public health surveillance and response systems?
Thank you very much. I think one important thing is that the measure of the efficiency or effectiveness of a health system, one of the easiest measures is death. We must count the number of people that are dying in hospitals. We must count, every village must count the number of people dying in the villages. We already have chiefs in the villages. Once we start counting, we'll know which villages are experiencing a lot of deaths. Then the next step would be to find out what are the causes of death. We need to strengthen that system so that we can know who's dying and what are they dying of. COVID is not the last epidemic to hit us. There will be other epidemics. A country like ours, at any time point, we must know who's dying and what they are dying of. When we know this information, then we will know what we need to be doing and what we need to be investing in. So one thing that we must invest very quickly on is to actually what we call vital statistics, knowing who has died, where they have died, and why they have died. Because then having that information then will enable us to know which disease is causing problems and which interventions that we need to implement at the community level. So I think we should invest a lot, continue investing a lot in the community, because that's where the battle is. Just lastly, to mention that, yes, here we are talking about hospitals, but remember, 90% of the people with COVID, they're actually being cared of at home. So if 90% of the people at home, that's where we should invest. The HSAs, health surveillance assistance, those people need to be supported because they are providing care to 90% of the people that have this infection. So in a nutshell, focus on the community, the chiefs and the health surveillance assistants to give us credible data. Thank you.
Thank you, Prof. Whilst you're still speaking, I have another question for you. What areas of research would you recommend for the country to focus on with regards to the issue of COVID-19?
Excellent question. I think you have seen that the country for the past 3-4 months has been using information from different countries. We were actually projecting that we're going to have, was it like 80,000 deaths and so many infections? It was all wrong. Why was it wrong? Because we are using data, information from China to project what will happen in Malawi. So another lesson is that the government and even the private sector should invest in collection of primary data. What do I mean? We need to collect information from Malawi because it's only information from Malawi that will let us know what we should be doing. Maybe even now, what we are doing might not be the right thing because our interventions are based on information from outside. The basic information that we need to know now is that if one person has got COVID in the house, how many people is going to infect, right? Something that, this is a basic information. How quickly can COVID spread in the population? At the moment, we're using data from other countries. Even that basic data we don't have. Thank you very much.
Thank you very much, Professor Malbata. We will now move to the question and answer session. But then as we are transitioning, there's a question on the screen. It's going to do with the issue of human resources for health, and I'll let you, Dr. Bridget Mario-Esi, to respond to that question. So the question has been posted by Felix Dimbani. And Felix says the issue of financial incentives in bracket risk allowance to health workers, did it do more damage to COVID-19 response? Could it have been managed differently?
Thank you so much for that question. And I think I will respond to maybe with Dr. Goma and certainly Dr. Costo because I think Dr. Goma said that staff that he was managing with him that. I think that there's two issues here. There's definitely the risk allowance, which was general across all health workers, because health workers, COVID-19 is not the only disease that they're affected by or at risk for. And I think that one, in general, the basic one was fine. I think where the initial idea for getting incentives, again, just reflecting back about the anxiety that staff have to try and manage patients, was to try and incentivize them to come and manage cases where disease that is new, that is unknown. And I think that the original concept was in good faith. Unfortunately, I think the question is coming because it was unsustainable. And we saw, for example, that there's a lot of treatment facilities closing because people did, the doctor said we're not going to manage one of their money. There were all kinds of, we were all trying a lot of money, couldn't manage that. So I think that certainly there might have been alternative ways to manage that. And I think by the time we were thinking, let's stop, or thinking around, should we stop incentives? Others were like, but you pay these ones, why don't you pay us? So possibly, yes, I think that there was maybe an alternative way we could have done it, but it started with good faith, and unfortunately the outcome just didn't work out the way it should have.
Thank you, Dr. Mario-Esi. Dr. Ngom, you also.
Thank you very much. First of all, as has been said, that COVID-19 brought a lot of fear. Seeing how people were dying in Europe, Italy, everyone here was affected. it was not easy at the beginning to find somebody to go and manage a COVID patient in an isolation center, which in essence means these health workers demand incentives for them to go into the isolation center. But also there was another blanket risk allowance, which everyone demanded. In essence, this is a lesson that it is important for the system to be for the networkers, because we've noticed that this risk allowance has been at 1,500. I joined the Ministry of Health in 2000. I found it at 1,500 per month. And in 2020, it was due 1,500. So that's a problem. It's a problem within the system, such that indeed people were saying, what kind of risk will I be giving more than 500 a month, which if they calculate per day, how much are you giving me a day? So in essence, it is important. And as you have said, that as my friend George said, that all the sectors came to their needs, and it was the health system which everyone relied. And COVID-19 is not the end, as we said. This is not the end of the pandemic. There will be pandemics, and the system should make sure that the people who are at risk, people in the hospitals, they get infected from so many diseases, not only COVID, a lot of them, TB, hepatitis B, a lot of them, and compensation is not as adequate, and it's even very difficult to say. For example, if I have hepatitis B, did I get it from where? Did I get it from outside? The same story happened with COVID for the health workers who tested positive for COVID. That they get it from where they go socialize. Did they get it from where? What is it? So it is an important area which the policymakers should always look at and make sure it's supported.
Thank you very much, Dr. Mona. Now, I'm moving to Dr. Nelson Fonseca. Are we happy as a country on how we have managed the COVID pandemic up to this far?
Can you come again, please?
Yes, I'm asking that as a country, are we happy with the way we have managed COVID-19 so far, COVID-19 pandemic?
Thank you very much, moderator. I will say we are happy because we are lucky. Because we are lucky, we didn't have the impact as some other projections shown, but we can do better. This is the reason why we're having this discussion. There's need to find means and ways of making the system so resilient. Otherwise, if Malawi was affected or Africa was affected the same Europe was affected, maybe things would have been worse. But we are lucky we didn't go that direction. But definitely, I wouldn't say I am that very much happy that we responded better. We could have done much better, because in the response, government or Ministry of Health had made very good plans, but in execution of those plans, some of the things were very slow. Like, for example, procurement of equipment for our hospitals. Up to now, some of the equipment is not yet in the country because of the challenge that the whole globe was affected with this COVID-19. However, whatever we did was supposed to have been done yesterday. I just want to take advantage to comment on what my colleagues, Dr. Malawi and Dr. Ngoma, have already commented. I think it's high time we start valuing our healthcare workers. And it was very nice to hear, to see some other quarters recognizing them as heroes for the first time. The healthcare workers have been heroes for the first time. And some people came to pat on their back and possibly to encourage them. This was very nice, and I think what we need to pick up a lesson from there to see how best can we take care of our human resource for health. Because the human resource for health is the one that is going to sort out all this that we're talking about. But as long as we don't have good policies, or we don't revisit our policies in terms of human resource for health and how we're going to take care of them, we may want to, we will not get where we want to get, and we cannot say we have done better. But we have got to, there's a lot of room for improvement. Thank you very much.
Thank you. We have 2 minutes left. I'd like to move to Dr. Mulina Nyirenda. There's a question for you. Based on your experiences in the hospital, what would be your priority recommendation in improving the level of preparedness in case of future epidemics? This question has been asked by Felix Newman. Over to you.
Thank you for that important question. It is a multifaceted answer, so I'll quickly go through the points. 1, we should have well-defined and flexible patient care pathways that will allow us to evaluate and look after patients properly when they come into the hospital. And it should have the appropriate processes, inputs and outputs that will help us to look after these unplanned visits. The next thing is that health workers, as we've been discussing, should be pluripotent regardless of specialization or alignment to disease programs, and they should be able to provide emergency care provision. Because in disasters, we need everyone who is available. The other bit is to facilitate integrated care planning that allows everyone to be on the drawing board and understand one another on how hospitals function, so that indeed specialized care is cohesively being provided within a structure that can respond to any other demand that arises. Community engagement and participation in service provision, design and delivery is of great importance. And the Ministry of Health has got an amazing structure that has community advisory boards that provide information towards the hospital designs and health services. That needs to be optimized. Of pertinence is to realize, as we've been discussing, today is COVID-19. Tomorrow it could be some other life-threatening disaster. We need to have particular isolation centers or areas within our hospital that can provide care safely with appropriate prevention safety measures without compromising other normal health services. And then indeed, drills are always important to prepare people in terms of how they can respond in their emotional, psychosocial response. Thank you.
Thank you very much, Dr. Mulina Nyirenda. We would have loved to continue with this discussion, but due to time constraints, we have to wrap up. And before we close this session, let me just take the opportunity to thank the panelists, starting with Dr. Ngoma, the Director for Family Central Hospital, Dr. Bridget Malewezi. She's an expert in human resources for health. And there's Professor Victor Mapasa. She's an expert in public health at college and a professor at College of Medicine. Dr. Denison Fosiko, the Deputy Director for Preventive Services, and Dr. Mulina Nyirenda, who is the Chief Specialist at Queen's, and Mr. George Yobe, the Executive Director for Malawi Network. And lastly, let me also once again thank our sponsors who have made this conference possible, starting with the Ministry of Health, the UNICEF, World Health Organization, First Capital Bank, John Hopkins Project, Malawi Welcome Trust, and and also let me thank you our viewers wherever you are watching. Thank you very much.
Thank you. Thank you.
Thank you.
Thank you very much. Thank you.
Thank you. Thank you very much.